So, very good evening to one and all. I am Dr. Amrita Sao, Senior Resident in Department of Pathology, Amrita Institute, Kochi. On behalf of IAPM Kerala Chapter, it is my pleasure to welcome you all at this expert talk on diagnosis of lymphomas. Diagnosis of lymphomas is challenging, as we all know, as it takes not only knowledge but experience and a whole lot of ancillary tools for the final conclusive diagnosis. Knowing everything about lymphomas is impossible, but having a panel of experts in the field to talk about would definitely help. IAPM Kerala Chapter is excited to have a group of renowned hematopathologists for this series, which would also help us in understanding the subject better for our next upcoming 87th IAPM Kerala Chapter meeting, which is based on the theme of pathology of lymphoreticular systems. So without delay, let us begin with this academic extravaganza. To start with, I invite Dr. Nobin Babu, Secretary IAPM Kerala, for the welcome address. Over to you, sir.
Hi all. It's my pleasure to welcome everyone for the third three-day webinar session, Diagnosis of Lymphoma, Hear It From Experts, organized by IAPM Kerala in association with Mindray India. I welcome all the eminent speakers, namely Dr. Madhu Menon, Associate Professor, University of Utah School of Medicine, Dr. Jayalakshmi Panikar Balakrishna, Assistant Professor, Ohio State University, Dr. Girish Venkataraman, Associate Professor, University of Chicago, Medicine and Biological Sciences, Dr. Raju Pillai, Assistant Professor, City of Hope, National Medical Center, Durant, Dr. Genevieve M. Crane, Associate Director, Cleveland Clinic Foundation, Cleveland, and Dr. Karthik Ganapathy, Assistant Professor, University of California, San Francisco, who have come to share their knowledge and vast experience with us. I extend my hearty welcome to all the moderators, namely Dr. Rekha Nair, Director, Regional Cancer Center, Trivandrum, Dr. Elizabeth Fisher, Professor, MOSC Medical College, Kolanjeri, Dr. Marie Teresa Manipadam, Consultant Histopathologist, Kent, UK, Dr. Sumit Gujaral, Professor, Tata Memorial Hospital, Mumbai, Dr. Neena Mambali, Senior Consultant, Baby Memorial Hospital, Calicut, Dr. Ajit Nambiar, Director, Kirkinos Healthcare, Kochi, Dr. Sangeeta Nayanar, Professor, Malabar Cancer Center, Talasheri, and Dr. Jayasudha A.V., Associate Professor, Regional Cancer Center, Trivandrum. This meeting would not have been possible without the support of Mindray India. Hearty welcome team. Lastly but not the least, I extend my warm welcome to all the IAPM Kerala chapter members, other state IAPM chapter members, and also all delegates across the globe who have registered and attending the conference from various places. Promising everyone a grand academic feast during these days. Thank you all.
Thank you, sir. Now I invite Dr. Rajan, President IAPM Kerala, for the presidential address.
Good evening to all the chapter members, fellow pathologists across India, across continents, and special good morning to all the faculty members from US. It is a unique and proud and exciting moment for IAPM Kerala chapter and to me as president to organize and materialize an international webinar on an important topic like lymphoma. The idea of having this was based on the thought that our upcoming 87th chapter meeting, the slide seminar topic is on lymphoreticular system pathology. You know, all general pathologists are generally lymphomaniac in one or other way, as they know how difficult sometimes make a diagnosing lymphoma and subtyping lymphoma. So we thought of conducting a lymphoma webinar prior to the chapter meeting. I discussed this with Dr. Marie Teresa, Professor CMC Vellu, who is now in UK Kent on sabbatic. From her, I got two contact hematopathologists, Dr. Jaya and Dr. Girish Venkataraman. And finally, they made themselves expanded the program, adding few fellow hematopathologists, Dr. Raju, Dr. Karthik Ganapathy, Dr. Madhu Menon, and Dr. Crane. So our next challenge was the time zone. And Dr. Malini Ipan from Amrita Institute of Medical Sciences helped me a lot to sorting out the time zone. Thankful to Dr. Indu R. Nair, Professor, Amrita Institute of Medicine, for the help rendered in several occasions. The most crucial thing was to get a professional team to help us with a platform. We approached the Mindray India to support us. Thanks to Dr. Ashik, MES Medical College, Perindalmanna, for the support given. Mindray India helped us to make this venture truly international. The brochure and the program with the link went to every nook and corner of the world. Thanks to Nikhil Khajwani, the marketing and the communication manager.
So you got muted.
Naveen Prakash, the regional manager.
Now it's okay, sir.
Yeah. Naveen Prakash, regional manager, Kerala zone. And big thanks to the entire Mindray team for the support given to us. We will have further association in future, and special mention to Dr. Sumit, the TMH Mumbai, and the Lymphoma Group, India, for their support. We got the right person to chair the first session. That is the first lymphoma specialist from Kerala, Dr. Rekha Nair, presently the Director, Regional Cancer Center. Once again, thanks to all for participating in this event. And the coming 3 evenings, let the lymphomania present. Thank you all. Thank you very much.
Thank you, sir. So the wait is over. We start with the first session of our day. I invite Dr. Indu Nair, Clinical Additional Professor, Pathology, Amrita Institute, to introduce our moderators. Madam has completed the observership at Imperial College, UK, and specializes in lymph node and gynec pathology. Welcome, Madam. Over to you.
Thank you, Amrita. Good evening, all. It's my pleasure to invite Rekha Nair, a renowned hematopathologist and currently the Director of Regional Cancer Center, Trivandrum. Madam is the first pathologist in the country to become the Director of a cancer center. And her expertise in hematopathology spans for more than a quarter of a century. She is trained under Professor Elaine Jaffe of NCI USA and has established and standardized the immunohistochemistry, flow cytometry, FISH, and molecular laboratories in RCC, the first of its kind in Kerala. And she is a holder of 5 international patents for discovery of microRNAs in breast carcinoma and has more than 60 publications to her credit in peer-reviewed journals, both national and international. A hearty welcome to you, ma'am.
Thank you, Dr. Indu, for that introduction. Thank you, Dr. Rajan and IAPM team for inviting me to moderate this session. It is close to my heart, lymphoma diagnosis. And I'm very happy also to see that the whole team is from the US, mostly youngsters. So the speaker for today's talk is Dr. Madhu Menon. I will introduce him. He is currently the Medical Director, Hematopatology, ARUP Laboratories, and Associate Professor, Department of Pathology, University of Utah School of Medicine. He took his MBBS degree from Baroda Medical College and his PhD in molecular medicine from Penn State University. He has American Board of Pathology certification in anatomic and clinical pathology and hematology. He did his fellowship in hematopathology, the prestigious Laboratory of Pathology, National Cancer Institute, US. He is recipient of several prestigious awards and fellowships. He has several invited talks, CME presentations, and lectures to his credit. His CV is running into pages. I found it very difficult to summarize. He is a reviewer of many journals, prestigious journals, and is a chapter contributor to many books in hematopathology. He has published more than 30 articles in peer-reviewed journals. And today he will talk on approach to diagnosis of lymphoid proliferations, lymphoma mimickers, and morphological clues to the diagnosis of lymphoma, which I think in itself it's a huge topic. So I will invite Dr. Menon for the talk. The stage is yours, Dr. Menon.
Thank you very much, Dr. Rekha, for that kind introduction. And it's a privilege to be introduced by you. It's a privilege to be here as one of the panelists and speaker for this 3-day lymph node pathology webinar series. I'm hoping that this is helpful and beneficial to everyone, including trainees and practicing pathologists alike. Kudos and a great thank you to the organizers, I think especially Dr. Rajan, Dr. Jaya, Dr. Girish for putting this group together. It's never easy. So let's get started. I will share my screen and hopefully that goes through smoothly. I hope everyone can see my screen.
Yes, yes, it is visible.
Yes, sir.
Okay, thank you.
You can make full screen, right?
Yeah. So, I've been tasked with this really ambitious topic of addressing. Just give me 1 second. I'm trying to get to the original screen. Yeah, so I've been tasked with this really ambitious topic of, how to approach lymph nodes, how to tackle some of the lymphoma mimics, and also discuss some of the benign lymph node lesions along the way. It's a lot to discuss in 1 hour, and I thought the best way probably is to approach this by presenting a few cases, and along the way we will elicit some differential diagnosis, and I'll also be posting some questions for the audience, and I'm really hoping that everyone participates in these questions. It's of course de-identified. The final answer would be in the form of a percentage. So let's dive into it with a brief introduction to lymph node histology. So as you know, lymph node is basically lymphoid tissue that's invested in a capsule. It has efferent lymphatics and efferent lymphatics, and it can be basically broken down into 3 compartments, 3 main anatomic compartments. You have the cortex, which is where the B-cell area exists. You have the paracortex just below that, which mostly houses the T cells. And then you have the medulla, which has the medullary cord and the medullary sinuses. So this is the H&E counterpart of that cartoon. And as you can see, these are all follicles that you see in the cortex. The paracortex contains your T cell areas, and this would be what in the old days we used to call nodular paracortical hyperplasia. And then you have your medulla with the sinuses. So a morphologic approach to lymph nodes really has to start from the outside. You have to first look at the capsule and ask these questions. Is the capsule thickened? Is it inflamed? Do you see plasma cell infiltrate? Do you see atypical cells, etc.? After that, one has to really examine the subcapsular sinuses. We as hematopathologists tend to be enamored by the lymphoid tissue, and unfortunately sometimes forget to look at the subcapsular sinuses and ask the questions: is it intact? Is it obliterated? Do you see atypical cells? Do you see metastatic carcinoma cells? And so on and so forth. And finally, the architecture. This is what we love to talk about. Is the architecture intact? Is it altered? Is it effaced? And we use the word effaced as a synonym sometimes for indicating that this might be a lymphoma. And effaced essentially means that you're not able to delineate the B and T cell areas and everything is blurred into one. In a intact architecture lymph node, one has to look at the cortex, look for follicles, look at the interfollicular area, look at the paracortex. Is it expanded? Is it cellular? And if it is cellular, what's the cellular composition? Are they mostly small lymphocytes, large cells, immunoblasts? Do you see increased vascularity? Do you see Reed-Sternberg-like cells, and so on and so forth? And then look at the sinuses. Is the sinus intact or is it obliterated? In most lymphomas, your sinuses tend to be obliterated. And then do you see atypical cells? Do you see Langerhans cells? Do you see anaplastic cells? ALCL, anaplastic large cell lymphoma-like cells, they tend to be mostly in the sinuses. And then finally, an examination of the medulla. Do you see increased plasma cells in the cords? And then look at the sinuses. So this is what the cortex looks like. It's got these nice follicles. This is the paracortex, and this is the medulla. And as I mentioned before, the cortex is composed of these B-cell areas, which light up with the most common immunostains that we use, which is CD20, PAX5, CD79A. You can use other B-cell markers if you want, like OCT2, BOB1. And the T-cell zone essentially has these T-cells which express all the T-cell markers. And when you look at the follicles, you have to distinguish between a primary follicle and a secondary follicle. Primary follicles are those which have not had any antigenic stimulation, so they lack germinal centers. Sometimes they can be mistaken for follicular lymphoma, but of course, if you go high power, these don't have centrocytic morphology, and they don't have germinal center phenotype. So these are mostly IgD positive mantle zone cells, and they're going to be negative for BCL6 and CD10. The secondary follicles, of course, have a germinal center because they have had antigen exposure, and through a series of interactions, they form these germinal centers. The germinal center examination includes looking at polarization. And what do I mean by that? Polarization means you have a dark zone on one end, you have a light zone on the other one. And the dark zone has more central blasts, and it has these tingible body macrophages, which create these holes at low power. And the light zone, of course, is composed of mostly centrocytes. This whole germinal center is invested by the mantle zone, which consists of smaller cells with scant cytoplasm. So when you approach these lymph nodes, especially reactive lymph nodes, there are a few patterns that you commonly see. You either see a follicular pattern, you see a paracortical or interfollicular pattern, you see a sinus pattern, you see something with extensive necrosis, or sometimes you see a lot of granulomas. Now, most reactive lymphadenopathies exhibit a mixture of these patterns, and then you might have one pattern that is more prominent. So for the sake of today's presentation, I'm going to be focusing mostly on the follicular and paracortical patterns. And of course, some of these entities would have some other patterns being also represented. So when you talk about a follicular pattern of reactive lymphadenopathies, it's a long list, but you mostly see that in patients with rheumatoid arthritis, Sjogren's syndrome, IgG4 related disease, Kimura, toxoplasmosis, syphilis, Castleman's, HIV associated lymphadenopathy, and PTGC. All of this show a follicular pattern of reactive lymph node enlargement. When you talk about paracortical pattern, I think the first thing that comes to your mind is, of course, non-specific reactive paracortical hyperplasia, which is something we very commonly encounter when you're examining lymph nodes. You can also have what is known as nodular paracortical T cell hyperplasia, where these actually form nodules and they have admixed dendritic cells. You can have dermatopathic lymphadenitis if you have pigmented cells, and this is also something that we very commonly encounter. But when you look at paracortical expansion, the most common association is actually with viral entities, such as Epstein-Barr virus, CMV, herpes virus, etc. You can also see that in the context of drugs and post-vaccinal, and also in IgG4 related disease. So with that, I would like to dive right into case number 1. This is a 64-year-old male with systemic lymphadenopathy for which an axillary lymph node biopsy was performed. And at this low power, you can see that the architecture is intact, meaning you have all your follicles evenly spaced, although they do appear quite hyperplastic. So at this power, of course, follicular lymphoma remains in the differential. Then you go 1 power higher, you actually start seeing polarization of the germinal centers and distinguishable body macrophages. So they don't look that ominous anymore. This is most likely a reactive germinal center. And if you go high power, it's a mixture of centrocytes and centroblasts. And along with that, you see a lot of these cells with amphiphilic cytoplasm and eccentric nuclei. So these are all increased plasma cells within the germinal center. So this brings us to our first audience question for today. What do you think is the most likely diagnosis? Is this HIV lymphadenitis? Is this plasmacytoma? Is this Castleman disease? Is this IgG4 related lymphadenopathy? Or is this a syphilitic lymphadenitis? Dr. Philip, could you please pose the question?
Yes, okay.
So we'll wait for a few more seconds. Okay, I think we can end the poll, Dr. Philip. So I hope all of you can see the poll results. If not, I can just say it out aloud. So 39% of the participants, and that is the highest number, said it was IgG4 related lymphadenopathy. The second highest was 22%, and that was for Castleman disease. The third highest was for HIV lymphadenitis, that was 20%. 13% said this was syphilis, and only 6% said this was a plasmacytoma. So thank you all for participating. So it seems like most people got it right. The answer is indeed, in this case, IgG4 related lymphadenopathy. But all of these, are good differentials. I mean, it's not HIV lymphadenitis, probably because in most cases of HIV lymphadenitis, you see a mixture of both reactive follicular hyperplasia as well as follicular lysis and PTGC-like changes. Usually the mantle zones are attenuated. You don't really see that. And you would see some expansion of the paracortex with vascularization. But of course, HIV lymphadenitis can have increased plasma cells. Plasmacytomas are extremely rare in the lymph node, and generally they don't just limit themselves to the germinal center. You will see them in between the germinal centers and also in the paracortex. So I think that is less likely, I would say, just because of the morphology that we see here, with most of the plasma cells being limited to the germinal centers, at least based on the H&E that I showed you. Castleman's, again, we are not seeing really diminutive germinal centers or atretic germinal centers, which we should see. And syphilis also can have increased plasma cells. However, you would generally see thickening of the capsule and infiltration of the capsule by plasma cells. So this is the second audience question. What are the next steps? And this should be fairly straightforward. Should we do IgG4 and IgG immunostain? Should we do kappa and lambda immunostain? Should we call the clinician and inquire about history? Should we check IgG4 levels, or all of the above? So Dr. Philip, please pose the question. Yeah, I think we can stop the poll here. I think most people agree that it should be 5, meaning that it should be all of the above. IgG4 levels, it's not always helpful, even though I put it in there, but you can have IgG4 disease in about 20% of the cases without increased IgG4 levels. And on the flip side, high IgG4 levels do not necessarily mean it's IgG4 related disease, because you can see increased IgG4 levels in various other entities as well. But it's good to check. So this is MUM1. I also did a CD138, and the plasma cells were increased in the germinal center and a few in between as well. This is kappa lambda-ish, which demonstrates that the plasma cells are polytypic, and the IgG4 and IgG stain demonstrate that there's a marked increase in the IgG4 positive cells, both within the germinal centers and also in between. So I diagnosed this as reactive lymphoid hyperplasia with increased IgG4 positive cells, suggestive of IgG4 related lymphadenopathy. The patient did have increased serum IgG4 levels. The lab and imaging studies revealed autoimmune pancreatitis as well. And the patient was clinically diagnosed with IgG4 related disease and was started on steroids. So as you know, IgG4 related disease is a disease of the older adult population. It's more commonly seen in males. And it causes this inflammatory lesions, the prototypical organs being pancreas and salivary glands. And the morphology is that of tumefactive or tumor-forming sclerosis. You can also have lymphoplasmacytic infiltrate, obliterative phlebitis, and storiform fibrosis. And these are actually required morphologic criteria to make that diagnosis. And labs in most cases show increased IgG4 levels. As far as lymphadenopathy goes, it can appear before, concurrent with, or subsequent to the diagnosis of IgG4 related disease. And it can be mediastinal, abdominal, or axillary lymph nodes. So there are 4 possible scenarios in which we as hematopathologists or general pathologists might encounter a lymph node which has IgG4 related disease. You could have lymph nodes that were taken out as part of an excision of an extranodal organ. For example, a salivary gland gets taken out and a few lymph nodes get taken out along with that. Or you could have 2 separate sites. You could have a patient with systemic lymphadenopathy and also with extranodal disease, and you might get these 2 specimens separately, although in a patient who has simultaneous presentation. Most commonly, I think you already have a patient with an established diagnosis of IgG4 related disease based on biopsy of an extranodal organ. And then after weeks to years, the patient develops lymphadenopathy. And I would say this scenario C is probably the easiest to diagnose when it comes to lymph nodes. And that is the scenario that you should hope for as a hematopathologist, because then you can just call it outright consistent with known IgG4 related disease. The toughest scenario is when you first get a lymph node biopsy and the patient does not have a diagnosis of IgG4 related disease. And weeks to years later, the patient has extranodal involvement. This is where it becomes really tough to pull the trigger on IgG4 related disease in a lymph node. So as far as morphologic spectrum goes, 5 different types of morphologies have been described, although none of them are specific for a diagnosis of IgG4 related disease. You can either get type 1, which is multicentric Castleman-like, where you have these atrophic germinal centers and interfollicular plasmacytosis, and most of your increased IgG4 positive cells are in between the follicles. You can get what is known as type 2 follicular hyperplasia, which is the case I just showed you, in which you have increased IgG4 positive cells in between the germinal centers and also within the germinal centers. You can have intrafollicular expansion with marked vascularization, plasmacytosis, immunoblast, and some scattered eosinophils. And again, this shows increased IgG4 positive cells. You can have PTGC, or progressive transformation of germinal center-like morphology. And in this case, the increased IgG4 positive cells are mostly within the germinal center. And then the least common is this inflammatory pseudotumor-like or type 5, where the lymph node actually exhibits the end organ manifestations of IgG4 related disease that you're used to seeing in other organs like pancreas and salivary glands. So this is a lymph node that's essentially replaced by fibrosis. It's got the lymphoplasmacytic infiltrate and increased eosinophils, and of course, it's positive for IgG4. So there was a really nice paper published way back in 2012 by Vikram Deshpande and group, where they came up with the consensus criteria for IgG4 related disease. And the starting point is, of course, the characteristic histologic features of lymphoplasmacytic infiltrate, fibrosis, which is usually storiform, and obliterative phlebitis. And then they had numeric cutoffs for how many plasma cells, how many IgG4 positive plasma cells you require for each organ. You of course have to start out with a minimum of more than 40% ratio of IgG4 to IgG positive plasma cells. Now, this is good for most organs, but it's very hard to actually apply to lymph node because you very rarely see these three characteristic histologic features in a lymph node. So what we do is to count 3 high power fields. This is with a 40x objective. You look at the IgG4 IgG ratio, make sure it's more than 40%. You make sure that your IgG4 positive cells are more than 100 per high power field. This is the absolute number. It used to be 50, but now I think it's raised to 100 because that's got more specificity. And once you satisfy this criteria, and if a patient has documented IgG4 related disease, in your pathology report, you can just call it outright consistent with IgG4 related lymphadenopathy. If not, if there is no history of IgG4 related disease, then you have to exclude a few entities which can have increased IgG4 positive cells, like rheumatoid arthritis, Castleman's disease. And then if it is localized lymph node enlargement, then you say something like reactive lymphoid hyperplasia with increased IgG4 positive cells, and significance is unclear. If it is systemic lymphadenopathy, then there's a higher chance that the patient has IgG4 related disease, and you can modify your comments to address that. In any case, you need clinical correlation with imaging studies, and this is actually a clinical pathological diagnosis. So there's a recent study from Vikram Deshpande's group where, following this criteria, they found that the features that were more associated, not specific, but more associated with IgG4 related disease was actually interfollicular IgG4 plasmacytosis. So if you have interfollicular IgG4 positive plasmacytosis, you have higher chance of having IgG4 related disease. And also, if you have the end organ manifestation, meaning you have fibrosis with increased eosinophils, that is also more likely to be IgG4 related disease. So as a hematopathologist with a lymph node that looks reactive with very non-specific morphologic patterns, when should we really perform an IgG4 stain? So there's no right or wrong answer. I think we would all agree that if you have lymph nodes from patients with known IgG4 disease, you should do IgG4 stain. I do IgG4 stain on any case with increased plasma cells, especially if the patient has systemic lymphadenopathy. If I see a reactive morphology and a few increased plasma cells and the patient has systemic lymphadenopathy, I always do IgG4. Japanese group, this is a paper by Sato et al. They showed actually that 65% of cases that have PTGC-like morphology also tend to have increased IgG4. So that is also probably something you can consider. If you see PTGC-like changes, you might want to throw an IgG4 stain on that case. And if you have marked plasmacytosis, as a rule of thumb, if you're not able to explain that, it's prudent to do an IgG4 stain and also a kappa lambda to make sure it's not clonal. So what about lymphomas? Would you think about lymphomas? Yes, you can think about a B-cell lymphoma with plasmacytic differentiation. but not with this kind of morphology, right? I mean, you want to see increased B cells, you want to see monocytoid B cells, especially in marginal zone lymphomas. And eventually you want to demonstrate clonality by either flow or PCR. So again, we go back to architectural disruption and architectural alteration, which you want to see with a B-cell lymphoma. You might think of a T-cell lymphoma, especially ITL, especially if you have hypervascularity or if you have increased plasma cells and eosinophils. But look for cytologic atypia in your T cells, and look for immunophenotypic aberrancies. And if you have any doubt, you can do T-cell clonality by PCR. The pseudo-tumor type morphology can make you think of classic Hodgkin lymphoma, but again, you need Reed-Sternberg cells and you need the typical phenotype, which is 30 positive, 15 plus minus, PAX5 dim, and CD45 negative. And plasma cell neoplasms, always do a kappa lambda to rule that out. So I have a few photographs along the way, which I took using my Samsung phone, actually. Recently moved into the beautiful state of Utah, so I've been taking a lot of pictures. So this is the Bonneville Salt Flats. This is actually where most of the land speed records are made. So moving on to case number 2, this is of a 55-year-old male with massive bilateral cervical lymphadenopathy, for which a cervical lymph node biopsy was performed. And as you can see, there is some retention of the architecture. You can see these scattered germinal centers, although you would agree that there is marked alteration. There is this pale area surrounding these germinal centers. There's marked dilatation of the sinuses. You can think of sinus histiocytosis. And if you go higher power, you see that there is a marked increase in plasma cells and surrounding the sinuses. These are the medullary cords. The sinuses are expanded by histiocytes, lymphocytes, again, increased plasma cells. Then you see these large atypical cells with a round nucleus, prominent nucleoli, and a few cells in the cytoplasm of these cells. These are mostly lymphocytes and plasma cells. S100 stain nicely highlights this cell. And this cell also happens to be positive for CD68. And an IgG4 and IgG stain was done, and there's a marked increase in IgG4 positive cells in this case as well. So that brings us to question number 3. What is the best diagnosis for this case? Is this Rosai-Dorfman disease? Is this IgG4 related lymphadenopathy? Is this hemophagocytic lymphohistiocytosis? Is it classic Hodgkin lymphoma? Or is it Langerhans cell histiocytosis? Dr. Philip, yeah, thank you. Okay, I think we can stop the poll there. So I'm very happy that most people thought that this was Rosai-Dorfman disease. 50% of people thought. 20% actually thought hemophagocytic lymphohistiocytosis. 12% called it IgG4 related lymphadenopathy. And 14% thought it was Langerhans cell histiocytosis. So the answer in this case is sinus histiocytosis with massive lymphadenopathy, also known as Rosai-Dorfman disease, with increased IgG4 positive cells. So this cell is, of course, what we call as the SHML cell, and this phenomenon is emperipolysis. It's not hemophagocytosis because the cells are actually just passing through. They are not really being destroyed in the cytoplasm. So in this patient, the IgG4 serum levels were normal. The lab and imaging studies did not show any autoimmune pancreatitis. The patient was observed and subsequently the cervical lymphadenopathy resolved. So Rosai-Dorfman, as you know, is a disease of the young and presents characteristically with massive bilateral cervical lymphadenopathy. You can also have extranodal sites getting involved, mostly the skin, the upper respiratory tract, soft tissue, orbit, and bone as well. So you can definitely make a diagnosis of Rosai-Dorfman in extranodal sites. This is usually self-limited and rarely aggressive. One point which I forgot to make is that when you encounter Rosai-Dorfman disease in extranodal sites, it's actually less common to see emperipolysis. So that is one peculiarity of extranodal sites. The other thing to remember is that Rosai-Dorfman-like changes can be seen in both Hodgkin and non-Hodgkin lymphoma, and in that case, the more important thing is obviously to make the diagnosis of lymphoma. And there can be various differentials. You can definitely think of sinus histiocytosis, but those are histiocytes. They're not going to be S100 positive, and they're not going to have the classic morphology. Langerhans histiocytosis also generally tends to involve the sinuses, but they will have that characteristic morphology with linear grooves in the nuclei, and they will have admixed eosinophils. And of course, when in doubt, you can do a CD1A and Langerhans, which is going to be positive. Remember that Langerhans cells are also positive for S100. And then you can have involvement by Mycobacterium leprae or Mycobacterium avium complex. So if you have any questions about that, you can always do a Zeal-Nielsen or a Fight stain. And then storage diseases like Gaucher, for which you can actually do a PAS and iron stain. So what about these IgG4 positive cells in Rosai-Dorfman? So it is known that a subset of Rosai-Dorfman disease cases actually have increased plasma cells, and there are several reports on that. I did a research project at the NIH when I was a fellow there, and we actually looked at some of the cases from Dr. Rosai's registry of cases. And we found that almost 17% of these cases had an IgG4 positive IgG ratio more than 40% and had increased IgG4 positive cells. And we found that this subset tended to be males, and they were usually older patients. So really the question is, is this a subset of IgG4 related disease with Rosai-Dorfman-like changes? Or is this a Rosai-Dorfman with a relative increase or a reactive increase rather in IgG4 positive cells? It is kind of tempting to speculate that this subset, which has increased IgG4, might be more steroid responsive. Unfortunately, we did not have a lot of follow-up data, so these were just questions which we could not answer. So what about consideration for lymphoma? It really does not look like a Reed-Sternberg cell, but on a bad day, it might look like one. So, look for a typical RS morphology, and if when in doubt, you can do your Reed-Sternberg cell stains. And as I mentioned, on the flip side, Rosai-Dorfman-like features can be a red herring. So, and you could have both Hodgkin and non-Hodgkin lymphoma lurking in the background. So the important thing is not to miss that. I already spoke about Langerhans cell histiocytosis. And because you see so many plasma cells, one could think of a plasma cell neoplasm. You can always do a kappa lambda to rule that out. Moving on to case number 3. This is a 22-year-old Caucasian male with 5 centimeter mediastinal mass. There were no other systemic symptoms, and a biopsy was performed. And this case demonstrates intact architecture. The follicles are hyperplastic, although the germinal centers are atretic. Right off the bat, you notice that you don't really see sinuses, so they kind of appear to be absent or obliterated. And if you go high power, you see these really diminutive germinal centers, and you see 2 germinal centers within 1 follicle, or 3 maybe in this. So this is the so-called twinning of the follicle. Again, a higher power image of the same phenomenon. And you can see hyalinization of the germinal center here with marked expansion of the mantle zone, the so-called onion skinning of the mantle zone. And it also has these lollipop lesions. These are basically sclerotic blood vessels which radially penetrate the germinal center. So I'm throwing a lot of buzzwords. I'm sure it's fairly obvious what this is. And along with that, there were these clusters of these cells. They kind of look like germinal center cells, except I didn't really see a mantle zone around it. And if you go high power, you can of course see tingible body macrophages, and you don't really see polarization. You don't really see classic centrocytic or centroblastic morphology. Rather, you see these cells which kind of look like plasma cells, but they have more of an eosinophilic cytoplasm and not as amphophilic as you would expect for a plasma cell. The nucleus is kind of vesicular, has maybe small nucleoli. So the question is, what are these cells? This is question number 4. Are these plasma cells? Are these centrocytes? Are these plasmacytoid dendritic cells? Are these monocytoid B cells? Or are these Langerhans cells? It's interesting. I think we can stop the poll there. We have a pretty good sampling. So I'm really happy and glad that most people did not think it was a plasma cell. Most people actually thought it was a plasmacytoid dendritic cell, almost 54%. 30% thought it was monocytoid B cells. And yes, one could possibly think about that. The only difference is that in monocytoid B cells, generally you see admixed neutrophils. You don't really see this amount of apoptosis, and the cytoplasm is generally clear, maybe slightly eosinophilic, and the nucleus is different. It has folding. So it's not monocytoid B cells, it's plasmacytoid dendritic cells, and it's definitely not the other cells. So this was a CD123 stain that was done, and it's strongly positive in that cluster. So the other cell which I encountered in the paracortex was this cell, and this is in the same case. And that brings me to my question number 5. What is this cell? Is this a Warthin-Finkelday cell? Is this a dysplastic dendritic cell? Is this a mummified Hodgkin cell, or is it HHV8 infected cell? I think we can stop the poll. We have a very good sampling. So it looks like most people were split. It's very interesting. 34% thought it was Warthin-Finkelday cell. 36% thought it was dysplastic dendritic cells. 20% thought it was HHV8 infected cells. So the answer is this is actually a dysplastic dendritic cell, and this can be seen both in the germinal center. You have the dysplastic follicular dendritic cells, but you can also see dysplastic dendritic cells outside of the follicle in the paracortex. Why is it not Warthin-Finkelday? It's just the context. I mean, Warthin-Finkelday tends to have more of a multinucleation. This is more dysplastic, and it would make sense in the context of the disease that we are encountering here, and that is a hyaline vascular Castleman lymphadenopathy. And as you know, it's very common to see these dysplastic dendritic cells, and some of them can actually progress to an FDC sarcoma as well. So this is the most common subtype of Castleman's disease. It happens mostly in the younger patient population. It's usually a solitary lymphadenopathy, commonly in the mediastinum, and the cure is surgical excision with or without radiation. You could think about a burnt out HIV lymphadenitis in some of these cases, especially with the marked hypervascularity. But I think the biggest difference between HIV lymphadenitis and Castleman's disease would be, I think, the lack of hyperplastic mantle zones, which is something that you see in hyaline vascular Castleman. As you know, HIV lymphadenitis, the mantle zones generally tend to be attenuated or sometimes absent. And then, of course, lymphomas with Castleman-like changes, similar to Rosai-Dorfman-like changes. The important thing is to actually diagnose the lymphoma. The Castleman-like changes are secondary and maybe not as important in that case, unless you're dealing with something like an HHV8 positive plasma cell variant, which progresses to an HHV8 positive lymphoma. That is a different context. And this is another case where you had these small germinal centers look very similar to the previous case, but this one had sheets of interfollicular plasma cells, which were CD138 positive. And in the mantle zones, I saw these cells, which essentially had amphiphilic cytoplasm, had a vesicular nuclei with a very prominent nucleolus. And so these are plasmablasts in the mantle zone. And these were nicely positive for HHV8 immunostain. They were also positive for viral IL-6 stain. And interestingly, when we did a kappa lambda stain, they were all lambda positive and kappa negative. So these are actually lambda restricted plasmablasts. And this phenomenon is interesting because these are monotypic but polyclonal by PCR. So Dr. Ethel Caesarman's lab has done some work on this, and the thought process is that, or rather thinking is that the naive kappa positive B cells are infected by HHV8, and a BCR revision happens, which leads to a switch to lambda, and then eventually the kappa gets deleted out. So that's the reason why you see excess of these lambda positive cells. So this is a no-brainer. It's a plasma cell variant of Castleman lymphadenopathy. So this brings us to question number 6. All of the following can be seen in plasma cell variant except, again, this is one of those except trick questions, so be careful. So all of the following can be seen in plasma cell variant except atretic germinal centers, onion skinning, vascular proliferation, presence of dysplastic dendritic cells, or follicular hyperplasia. So I think we can stop the poll there. So interestingly, I would say 42% thought, or majority of the people thought that it is follicular hyperplasia. The next highest was vascular proliferation. And the next one was presence of dysplastic dendritic cells, and then followed by atretic germinal centers. So the answer in this case is presence of dysplastic dendritic cells. So you can see all of these with the plasma cell variant. A plasma cell variant can have atretic germinal centers, just like hyaline vascular. It can show onion skinning. It can show vascular proliferation. And actually this term follicular hyperplasia is accurate, but sometimes when we talk about follicular hyperplasia, we only think about germinal center hyperplasia. The follicles are hyperplastic in Castleman's disease. It's just that the germinal centers are atretic, but the mantle zone is hyperplastics. So you can see follicular hyperplasia in both your plasma cell variant as well as your hyaline vascular Castleman. The only thing which you do not see in the plasma cell variant is dysplastic dendritic cells. So that is the answer. So as you know, this happens mostly in older patients. There is an association of HHV8 in about 50% of the cases. And this entity tends to be associated with more severe systemic symptoms and also increased serum interleukin-6 along with polyclonal hypergammaglobulinemia. And of course, the entity which we all know about is the multicentric Castleman, which mostly tends to be the plasma cell variant. And this one behaves more like a lymphoma with multiple sites being involved, marked B symptoms, and elevated ESR and LDH, and of course, increased IL-6 and polyclonal hypergammaglobulinemia. And this is the subtype that can also be associated with HIV and Kaposi sarcoma. It can also be associated with Poem syndrome. And this one usually has to be treated with steroids and or chemotherapy. So what about lymphomas? Again, you could think about a B-cell lymphoma with plasmacytic differentiation, but you have to see massive expansion of B cells into the interfollicular areas. You could think about an angioimmunoblastic T-cell lymphoma, but again, if you do a combined morphologic phenotypic approach along with possible molecular studies, you could rule that out. You could think about a follicular T-cell lymphoma. This is, of course, one of the TFH type T-cell lymphomas that have been described. And this can really have Castleman-like morphology. It can have nodular lymphocyte predominant like morphology. So one has to look for increase in T cells with the TFH phenotype. So you can do PD1, CD10, BCL6, CXL13. And if you're really in doubt, you can always do a T cell clonality test. So I find this extremely challenging sometimes to differentiate a follicular T cell lymphoma in these instances. A classic Hodgkin lymphoma, especially with those plasmablasts in the mantle zone, you could think about a lymphocyte-rich classic Hodgkin lymphoma, but these cells have more of a plasmablastic morphology. They don't really have Reed-Sternberg-like morphology. And of course, they will not have the classic immunophenotype of classic Hodgkin lymphoma. Then, because of the increased plasma cells, you could think about a plasma cell neoplasm. If you're really worried, you can do a kappa lambda. So moving on to case number 4, this is a 22-year-old female from Japan with fever and painful cervical lymphadenopathy, and lab studies were abnormal with increased ESR and LDH, and a cervical lymph node biopsy was performed. At low power, you can see broad areas of necrosis. This is a big necrotic area. And the paracortex appears to be expanded. So there is some distortion, but you can see the B cell areas. You can see the scattered follicles with some expansion of the paracortex. And again, you can see some necrosis here. And this area of necrosis is surrounded by these pale histiocytes. And if you go higher power, you can see a lot of fragmentation of the nuclei, a lot of karyorrhexis. But you do not really see neutrophils. And maybe I can go 1 power higher to prove that to you. So these are all fragmented nuclei, but you don't really see a good neutrophil in there. These are the pale histiocytes which surround these areas of necrosis. And you have, along with that, you have these crescentic histiocytes. They are so called because of this crescent-shaped nuclei. And these crescentic histiocytes are nicely positive for CD68 and also for myeloperoxidase. So these are actually modified histiocytes. And we again see these large clusters of plasmacytoid dendritic cells with these apoptotic cells in between. These are nicely highlighted by CD123. And the paracortex also shows increased proliferation of these immunoblast-like cells. And turns out that most of these are actually CD8 positive T cell immunoblasts. And there might be some B cell immunoblasts too, but most of them are T cell immunoblasts. So they should be fairly straightforward. Based on this, what is the best diagnosis? This is question 7. Okay, I think we can stop the poll there. So there is an overwhelming consensus. I think 89% of the people correctly diagnosed this as Kikuchi-Fujimoto disease. A shout out to 2% who thought that this could be lupus. Actually, lupus lymphadenitis can sometimes look identical to Kikuchi. And so in these cases, I always include that in the differential and ask them to do lupus serology. The classic hematoxylin bodies and increased plasma cells might not always be seen in these cases. So whenever you see Kikuchi-like disease, always ask the clinicians to do lupus serology and rule lupus lymphadenitis. As far as the other three entities go, I think all of these are associated with necrosis, but you would also see acute inflammation and you would see increased neutrophils. So this is Kikuchi-Fujimoto disease or histiocytic necrotizing lymphadenitis. As you know, this is common in young Asian females. You can have clinical symptoms of fever and chills. The most common presentation is that of a painful unilateral lymphadenopathy. And you could have abnormal labs. And sometimes you can see circulating atypical lymphocytes in the peripheral smear. So there are three different phases of this disease, the necrotizing phase and the xanthogranulomatous phase, as I showed you in this case, is relatively easy to identify. I think the tough thing is when you have a pure proliferative phase, where you just have these sheets of immunoblasts and PDCs and presentic histiocytes, and you don't really see necrosis. This is where this could sometimes be mistaken for a T-cell lymphoma. And I think the biggest challenge is to rule that out. And even though the T cells look atypical, they are not going to be immunophenotypically aberrant, and they're not going to be clonal. And I'm always reluctant to make the diagnosis of a T-cell lymphoma in a young patient regardless. So that's the caveat. When you see marked immunoblastic proliferation in the paracortex, when you mostly have these CD8 positive T cells, do not call that a lymphoma. I already spoke about lupus lymphadenitis, which I think is the biggest differential, and then various infectious causes. You could think about cat scratch lymphadenitis, but again, as I mentioned, this generally tends to have a mixed inflammation with neutrophils. And of course, you can do a Warthin-Starry stain for Bartonella, which will be positive. You could also have herpes in the differential, but herpes will have acute inflammation, necrosis, and of course, this Cowdery inclusions, which are these herpetic inclusions. And you can always do a herpes stain if you want to confirm that. And then toxoplasma might sometimes, but not always, enter into the differential. And this is the classic triad. We talk about hyperplastic follicles with follicular hyperplasia, monocytoid B-cell clusters, which are these cells, and then you have these epithelioid histiocytes impinging into the germinal center. So I already spoke about T-cell lymphoma, which I believe is the biggest pitfall for Kikuchi, especially in the proliferative phase. So a combined approach should rule that out. And classic Hodgkin lymphoma, mixed cellularity type, sometimes you might consider that. But again, you will have the classic Reed-Sternberg morphology and the phenotype. So moving on to the last case for the day. This is a 22-year-old from Japan with a retroauricular mass, and lab studies demonstrated increased IgE and eosinophilia. A biopsy was performed. And again, you see a relatively intact architecture, although it might be hard to appreciate based on this photograph. But you see these follicles. There is some expansion of the interfollicular areas with sheets of eosinophils and eosinophilic microabscesses. You have hypervascularity, and you have eosinophilic microabscesses, as I mentioned. This is a photograph of a germinal center, which appears to have been infiltrated by eosinophils. And this is again a germinal center, which is completely taken over by eosinophils and exhibits follicular lysis. So you know where I'm going with this case, I'm hoping. Then I saw a few of these cells scattered around. These look like grape-like clusters. So the next question, I would say probably the last question for this session is identify this cell type. Is this a Warthin-Finkelday cell? Is this a dysplastic dendritic cell? Is this herpes infected cell? Or is this a tumor giant cell? This is question number 8. I think we can stop there. So excellent. I think most people came up with the right answer. I think 71% said that it's a Warthin-Finkel-Day cell, and 18% thought it's herpes infected. Yes, I mean, I think it's not entirely unreasonable to think about multinucleation that you might see in herpes. But in the context of this case and the other findings, the correct answer is this is a Warthin-Finkel-Day cell. And the diagnosis is of Kimura lymphadenopathy. And as opposed to Kikuchi, which is common in young Asian females, this entity is common in young Asian males. And of course, you can have increased serum IgE and eosinophilia. This usually present as head and neck masses. Sometimes you can have deep-seated subcutaneous nodules, and kidneys can also be involved. The clinical course is that of waxing and waning, and it's not at all unusual for these lesions to actually recur after excision. So treatment in general is surgical excision with or without radiation, along with steroids. So I already spoke about the lymph node morphology and everything that I described in this case. So in the interest of time, I won't go through that again. I think in the skin, excuse me, in the skin, you can have reactive follicles, eosinophils and thin-walled capillaries. And the thing to remember is that this is usually very deep-seated in the skin. It's usually in the subcutis. And the most common differential diagnosis that you encounter is this entity, angiolymphoid hyperplasia with eosinophilia. This is actually thought to be a vascular neoplasm now. It is also known as epithelioid hemangioma. And this enters into the differential sometimes. But remember that this is more common in Caucasian females. It involves the superficial skin. It does not usually go deep. And there is never lymphadenopathy with this entity. The other differentials are, of course, parasitic infections and drug reactions, which have to be ruled out. In the context of lymphoma, when you see increased eosinophils like that, you have to make sure you're not dealing with a T-cell lymphoma or a classic Hodgkin lymphoma, and the same caveats apply as before. So in conclusion, reactive lesions can appear as lymphoma, but reactive lesions can also act as a red herring and can mask a lymphoma. So both situations have to be considered. And when in doubt, always use ancillary tools as needed, meaning your immunohistochemistry, flow, molecular studies, and maybe even cytogenetics and FISH if required. So thank you very much. And I think we'll take questions at this point.
We have a few questions here. Can you hear me?
Yes, Dr. Rick, I can hear you.
Regarding case 1, IgG4 related disease, the question is from the audiences, how to diagnose this on core biopsies?
Yeah, I think it will be very difficult to diagnose this on core biopsies. I mean, so there's two ways to handle this. One is if you see increased IgG4 positive cells, then you could sign it out in a descriptive fashion and say that increased IgG4 positive cells were noted. This could be an IgG4 related disease and correlate clinically. That's one way to address that. Now, should you ask for an excisional biopsy? I don't think you need an excisional biopsy on most cases, at least in this context. You could have other reactive entities, for example, like Rosai-Dorfman with increased IgG4 positive cells, which might not be reflected on your core biopsy. But in general, I'm not a big fan of core biopsies. I'm not a big fan of cytology for lymph node assessment. So you could sign it out descriptively, but in any case, I don't think you're going to be able to establish a definitive diagnosis unless the patient already has a history of IgG4 related disease.
I think that answers your question. Now, regarding the second case, Rosai-Dorfman disease, the question is, why wasn't IgG4 done at all in this case?
Yeah, that's a really good question. I think
our panelist, Dr. Nina.
Yeah, this was I think I'm trying to remember why it was done. this might have been, sometimes you do immunostains and sometimes it turns out to be serendipitous and you find something. I wouldn't say there was any indication to do IgG4 on this case. It was just ordered and it was discovered. Now that I know that there is an increased association with Rosai-Dorfman, I do order an IgG4 because I just want to document that IgG4 was increased in case that patient goes on to manifest a disease that is more like IgG4 related disease, So if I do see a typical Rosai-Dorfman these days, I always do an IgG4 stain just to rule out that possibility. But the same thought process I think might have applied, but sometimes, you order stains and I remember Dr. Nancy Harris once saying, I was attending one of her annons and she said that, never order an immunostain if you don't know how to interpret the positive or the negative stain for that. So so in this case, you don't really need to do an IgG4 stain, if that answers the question.
And another question related to case number 3 and 1, how to differentiate plasma cell Castleman disease HHV8 negative from IgG4 lymphadenopathy?
I think you can do an IgG4 stain, right? I mean, that would differentiate. I mean, if you don't see increased IgG4 positive cells, you have essentially ruled it out, at least in the context of that lymph node. So I think you can do an IgG4 stain for that.
Again, another question, will dysplastic dendritic cells stain with CD30?
Generally not. Of course, if you have the dysplastic FDC cells, they would stain with your FDC markers. So you would expect those to be positive, but generally you would not expect CD30 to be positive. Yeah. Mm-hmm.
I think that finishes the questions.
Okay, thank you very much.
Thank you, sir and ma'am. Now moving on to our next session, I again invite Dr. Indu Nair to introduce our next moderator for the next talk.
Thank you, Amrita. It's my pleasant duty to invite my friend, Dr. Elizabeth Fisher, to chair the next session. She is Professor of Pathology at MOSC Medical College, Kolanjeri. She has over 15 years of experience working in various institutions of India as well as in UK. And she has worked as consultant pathologist in breast and lymphoma pathology at Royal Stokes University Hospital, UK, and as consultant and head of lab at Apollo Hospital, Secunderabad. Her special interests include lymph node and breast pathology, and she has numerous publications, national and international, to her credit. Over to you, Dr. Elizabeth.
Yeah, thank you, Dr. Indu. A heterogeneous group of neoplasms with wide variation in prognosis under a seemingly innocuous umbrella term, lymphoma. For some, it is a nightmare, and for others, it is a passion. So, as the brochure for the webinar says, let us hear from the experts. Now, for those who might have joined a bit late, Dr. Madhu Menon, the Medical Director of Associated Regional and University Pathologist Laboratories, and Associate Professor at the University of Utah School of Medicine, is now giving his second talk on indolent and in situ lymphomas. Dr. Menon has an impressive CV to his credit, to which I wouldn't be able to do justice in the short span of time allotted to me. Suffice to say that Madhu has published 30 original articles in renowned journals, authored 5 chapters in pathology textbooks, mentored many trainees in research, and has been bestowed with numerous awards, the highlights being Teacher of the Year twice in the Henry Ford Pathology Residency Program. So, which are the indolent lymphomas? What are their characteristic features? Are they always indolent, or do they occasionally transform? And the in situ ones, the in situ follicular and mantle cell neoplasia. Are we often missing it, and how much does it matter? I'm sure all these and much more will be dealt with in today's talk. Over to you, Dr. Madhu, and a warm welcome from God's own country once more. Thank you.
Thank you very much for that kind introduction, Dr. Elizabeth. Yes, I think lymphoma diagnosis in general can be anxiety provoking sometimes, and also in most cases, though, it is exciting. So the second talk for today is with regards to in situ early and indolent lesions in hematopathology. Excuse me. So this concept of in situ and early lesions is pretty well rooted in the field of surgical pathology. I mean, we all know the progression of atypical ductal hyperplasia to invasive ductal carcinomas, tubular adenomas, which can transform to adenocarcinomas, and certainly the sequence of CINs finally leading to squamous cell carcinomas of the cervix. So for solid tumors, this concept of pre-malignant to invasive carcinoma is pretty well aligned and pretty well characterized with several morphologic criteria and genetic molecular events that have been described that leads to this progression. This concept is somewhat harder to apply in hematologic neoplasms because, as you know, hematopoietic cells travel as part of their either normal immune or hematopoietic functions, and they are not per se bound by anatomic compartments, although you do have anatomic barriers that exist in testis and CNS, but for the most part, these cells tend to travel. And so there is really no such thing as a benign lymphoma. Having said that, you do have indolent lymphomas, and these in situ lesions do exist, and they are getting more press these days. So I shared this cartoon with you, which we all have seen. This is an elephant being examined by a group of blind men, and each one of them touches a certain part of the body and comes up with their own interpretation as to what it is. So sometimes making a diagnosis of lymphoma or leukemia, for that matter, in isolation is somewhat like this. So in the modern era, as you know, the diagnosis of lymphoma or leukemia is highly complex, and the key word is integration, meaning that you acquire as many data points as you can, and these data points can come from clinical, morphologic, flow cytometric, cytogenetics of fish, and now the big elephant in the room is molecular NGS-based data. So try to integrate as many of these data points because eventually it leads to a better diagnosis. And the one thing to also remember as practicing hematopathologists, and this is something we really drill into the residents, is that clonality does not always equate malignancy. We can see clonal B-cell populations in various autoimmune conditions and various infectious conditions, hepatitis C, HHV6, and H. pylori being the most common offenders. And certainly clonal T-cell populations. The most common thing that we encounter is post-transplant LGL proliferations, which sometimes can be clonal. You can certainly see reactive skin lesions, which can be the bane of our lives, which pick up a T-cell clone. So the question of, is this really a T-cell lymphoma or a pseudo-lymphoma? And then you can see T-cell clones in hairy cell leukemias and MDS, etc. So today I will try to address the first half of my talk talks about these pre-neoplastic lesions or these in situ lesions. And I like to think of them as uninvolved. So the first entity I'm going to be talking about is monoclonal B-cell lymphocytosis. And in the back, I have a photograph of the NCI clinical building. This is the building 10, as it's called. And Bethesda is where the standardization of the term MBL happened after a meeting of the International Familial CLL Consortium and International Workshop on CLL. This was first found in normal unaffected siblings in patients with familial CLL, where if you do flow cytometry on their blood, you start picking up these B-cell clones. Then the increasing use of flow cytometry in the general population led to detection of these monotypic CD5 positive population in low numbers. Now we know that there is both a CD5 positive and a CD5 negative subtype. There is a wide prevalence. It's all the way from 0.8% to 12% that is described in the literature. This could be because, I would say this has to be because of the different sensitivities of the flow cytometry assays. As you know, higher the number of events you collect, the more sensitive your flow cytometry assay is. So the 2008 WHO classification for monoclonal B-cell lymphocytosis was a monoclonal B-cell population of less than 5 times 10 to the 9th per liter. And it could have 3 different phenotypes. It could have the so-called CLL immunophenotype, meaning it is CD5 positive, CD23 positive. It could have an atypical CLL phenotype, meaning it is CD5 positive, CD23 negative. And in these cases, you usually see a moderate to high level of CD20 expression on your B cells and 79B expression. You have the CD5 negative subtype of monoclonal B-cell lymphocytosis. And I would think that most of these actually correspond to lymphomas in circulation, most commonly splenic marginal zone lymphomas in circulation. So this is a typical dot plot of monoclonal B-cell lymphocytosis case. This is a CD19 positive population that also expresses CD5. The CD5 intensity is usually lower than your T cells, which are 19 negative, 5 positive. And they, of course, express CD23 very nicely. And they have dim CD20 intensity, and they have dim light chains. So this is a very nice example of a CLL type monoclonal B-cell lymphocytosis. Now, the updated 2017 WHO classification retains this definition of MBL, but it emphasizes differentiating the high count from the low count MBL. So what is that? So the high count MBL is when you have more than 0.5 times 10 to the 9th per liter of clonal B cells. And it is thought that these are closer to rise stage 0 CLL with similar genetic and molecular features. The progression to an overt CLL is about 1 to 2% in this cohort. So this is very similar to an MGUS progressing to a plasma cell myeloma. So the recommendation at this point for these patients is to do yearly CBCs and just follow up. And they have risk factors which are very similar to that we described for CLL, meaning positive for CD38, unmutated immunoglobulin, heavy chain variable region, and deletion of 17p, which, as you know, houses the p53 gene. And on the other side, you have the low count, which is less than 0.5. And this entity really has a very negligible progression. And until new data emerges, the general consensus is that there is no need to follow up these patients outside of just routine medical care. So there are some exclusion criteria for monoclonal B-cell lymphocytosis. You are not allowed to have lymph nodes that are enlarged more than 1.5 centimeters. You're not allowed to have organomegaly. But interestingly enough, what is not exclusionary, meaning that what is allowed within the broad umbrella of MBL is bone marrow involvement. You can have paraproteinemia. And interestingly enough, even cytopenias or disease-related symptoms are allowed in the context of MBL. So this is a slide from a paper by Dr. Marty. This is the British Journal of Hematology consensus paper. And the recommendation is to have a kappa to lambda ratio that is more than 3 to 1 or less than 0.3 to 1, and greater than 25% of B cells either lacking or expressing low-level surface immunoglobulins or having a disease-specific immunophenotype. Like everything else, you want to make sure that this population remains there for a reasonable period of time, because sometimes you can have clones that disappear. So the recommendation is to repeat the assessment and make sure that it is stable over at least 3 months period. And I already spoke about the exclusion criteria. So this brings us to the first question for this talk. This is a bone marrow in a patient with increased CD5 positive, CD23 positive clonal B cells in circulation. Just by looking at the bone marrow morphology and looking at this nodular aggregate, which is CD20 positive, and then looking at the somewhat diffuse infiltrates, And there is no right or wrong answer for this. So would you call this monoclonal B-cell lymphocytosis, or would you call this CLL, SLL? So please post the question. Dr.